morning, everyone. And my name is Morgan, a sports science student in the University of Limerick, and this is ULMedX, an exercise-based cardiac rehabilitation program that can or may prevent the onset of symptoms associated with frailty. So just to give a bit of background on what frailty is, it's a common syndrome of older adults resulting from age-associated declines in physiological reserve and function, such as age-related loss of muscle mass and quality. And it leads to an increased vulnerability for adverse health outcomes such as falls, hospitalization, and death. Now, falls occur at least once annually for about 30% of community dwelling adults over the age of 65, and they result from a combination of intrinsic and extrinsic factors. So when we talk about preventions, what we're really looking to modify would be the intrinsic risk factors, such as balance, muscular strength, and endurance. And then we have this situation where about 2/3 of adults between the age of 65 and 69 are currently insufficiently active, and this figure only rises with age. So the aim of this study was to assess the potential of an exercise intervention, being ULMedX, to improve physical health and prevent the onset of symptoms associated with frailty in community dwelling older adults. So what that essentially means is we wanted to see if ULMedX could prevent the onset of frailty. We had one group, and it was a pre-test, post-test design carried out over 3 months in the University of Limerick sports arena. The intervention itself consisted of bi-weekly multi-component exercise classes, meaning 2 classes a week, and multi-component meaning that it was a mixture of resistance exercises and aerobic exercises. The participants were 18 males and 10 females, with an average age of 72 years and a range of 65 to 82 years. And the study received ethical approval from the UL Research Ethics Committee. All the data was analysed using SPSS statistical software. So we ran descriptives to see if the data was parametric or not, and then appropriately paired sample t-tests or Wilcoxon signed rank tests were run afterwards. And all the testing was done at a 95% confidence interval. So the measurements we used were the 6-minute walk test to assess aerobic fitness. So what we did was we measured out a 30-meter track. It was on an indoor track, so we marked a start point and an end point with cones and 5-meter intervals in between. And we got the participants to walk from one end of the track to the other, turn briskly, and walk back and forth for 6 minutes continuously. And at 6 minutes, the test was terminated and the total distance traveled by each participant was recorded. We assessed hand grip strength using a hand grip dynamometer. It's a surrogate measure of upper body strength. So we would have had the participants hold their elbow at 90 degrees and squeeze the hand grip dynamometer as hard as possible for 3 seconds. We took 3 measures on each hand and the highest measure was recorded. Sit to stand test was used to assess lower body strength and dynamic balance. So the participants completed 10 repetitions as fast as possible, where they would rise from a seated position to a standing position and sit back down with their hands across their chest so that they weren't using their hands to get up. And finally, the single leg balance test was used to assess static balance and falls risk. So the participants stood on one leg with the other leg elevated, and they weren't allowed to use anything else to support their weight other than their standing leg. And they stood on their standing leg for as long as possible to a maximum of 30 seconds. And again, 3 tests were taken on each leg and the highest scores were recorded. And I said I'd throw this in there because as part of ULMedX, a questionnaire is also taken to assess qualitative stuff like quality of life and mediators of behavior. But for the purpose of this, I'm only looking at the quantitative stuff. Improvement of almost 60 meters in the 6-minute walk test across the 3 months, and broke down to be just over 70 meters for the 65 to 75 year olds and just over 30 meters for the 75 plus year olds. And I just put in this graph here on the right to show the individual differences from baseline to 3-month follow-up. So on the vertical axis, you can see age in years, and on the horizontal, the difference from baseline to 3-month follow-up in the 6-minute walk test. And it's just showing that the majority of participants did improve significantly, because sometimes mean improvements, they may not show you what actually happened on an individual level. So here you can see that the majority did improve, and that the improvement does appear to be slightly greater generally for the younger participants. With regard to the other 3 tests, we saw no significant changes. But this is also a positive finding, because normative data would suggest that performance across all 4 tests would decline with the age of the participants in this study. And like I said, all the tests not only remained stable, but they even saw significant improvements in the 6-minute walk test. But really what we want to know is, what would these mean for the individuals who are part of the test? So we have all these numbers and figures and results, but what could they actually mean to the quality of life and the lives of these individuals? So an improvement in aerobic capacity that was seen in the 6-minute walk test is an important predictor of mortality and morbidity. So morbidity meaning chronic diseases such as cardiovascular disease and type 2 diabetes, and mortality meaning death. So people who have a better aerobic capacity are less likely to have morbidities or die earlier. In terms of hand grip strength test, again, we see it's a predictor of all-cause death. So having greater or not seeing a reduction in hand grip strength is an indicator of a maintained risk of all-cause mortality. And lower sit-to-stand test, then lower body strength is associated with improved mobility. So the lack of a decline in sit-to-stand performance also indicates that the participants didn't have this improved mobility, which would be seen as part of the frailty syndrome. So that was a positive finding as well. So to date, exercise is the interventional modality that has most consistently shown to benefit in treating frailty. So we don't have, like, let's say your doctor or general practitioner couldn't prescribe any medication to treat frailty because there isn't any medication, but perhaps they could prescribe exercise, because what we know about exercise is that it can prevent the progression of frailty, improve the management of frailty, improve quality of life and ability to perform activities of daily living in frail individuals, and reduce the risk of falls in older adults in general. So maybe exercise could be the first line kind of treatment and preventative measure for frailty. Couple of limitations to the study.
Just to say, you have 1 minute left, Morgan.
Okay, thank you. So limitations, we'd no control. There was no measure of physical activity outside of MEDX, and there was no follow-up to those who dropped out. So the take-home messages are that an exercise intervention can improve aerobic fitness and may prevent declines in strength and balance in older adults. And exercise has positive effects on the progression of some symptoms associated with frailty. And then, so my screen froze there, but I just want to acknowledge Professor Catherine Woods, Dr. Raymond O'Connor, and Ms. Sinead Kelly, because without them, I couldn't have completed this research. I also wanted to thank the UL staff and clients who participated in the study, and finally to thank the Centre of Transformative Learning and UL for hosting AICUR 2021. So thank you for your time, and if you have any questions, I'll be happy to take them.
Thank you very much.